the side effects with the systemic side effects with losing bone. And one of the other questions was how often can you get those? I think in general, we tell our patients that usually 3 months or so, as long as it's those intra-articular ones, every 3 to 6 months is a good time frame. If they're not working the 3 months, I tell patients that's usually time to start thinking about surgery if they have the end-stage arthritis. Now, the lubrications, that's another one that I think it's sort of religion for doctors. My philosophy, and this is personal philosophy, is I usually would start with the anti-inflammatories to begin with because they do, first of all, they do have different actions, so they can complement each other. So we attack the inflammation first. But I have found that you have to have some cartilage left for the lubrication injections to work better. If it's already bone on bone, we definitely start with the anti-inflammatory, but I don't usually offer the lubrication injections for those kinds of patients. Just as a guideline. Now, and that's not written in stone, because definitely other patients can try the lubrications when it's bone on bone, but again, it's not you don't get the same kind of relief that you would see otherwise. Let me see. This is a question for Megan. You mentioned about for osteoporosis prevention, working on the upper extremities when you're walking. What kinds of things can you do to do the upper extremities, say while you're walking, which you're working on the lower extremities? What kind of exercises do you do to engage the other parts of your body?
Well, you can always do muscle building for your upper extremities. It seems to be most beneficial, though, if you can do something that's weight-bearing. So, that's why walking is more obviously going to affect your lower extremities because you're putting the weight through those bones. So in terms of upper extremities, if you can be educated on different exercises that you can do putting weight through your arms, if you're able to tolerate that, and if your other past medical history allows for that, there are exercises you can do putting weight through your arms. Obviously, just the regular strength training, though, is beneficial too, where you're just lifting weights or moving your joints of your arms without putting the weight through them.
I have documentation that what she's saying really works. Both my mother and my grandmother had osteoporosis and were bent over like this. And I was showing the beginning stages of osteopenia in my bone density scan. And I started doing weight-bearing exercises at the gym, not the dumb barbell kinds of things, but sitting and using the lifting exercises. And the next year, or maybe it was 2 years, I can't remember now, my bone density scan showed that I had moved out of that osteopenia range and back into the normal. And I was just talking to my doctor about it yesterday, and she said, yes, it was still holding.
Wow. Good. There it goes. What about yoga and Tai Chi? Where do they come in? Meg?
I think they're both beneficial, and I know a lot of people that really enjoy both, and they can work on flexibility, core strengthening, posture, strengthening overall. I know when I've done it, I can feel it afterwards, so definitely beneficial, and it's just another area of exercise that might be more exciting to you than just the walking.
Mm-hmm. Some quick ones too, sort of other follow-ups. How soon after surgery can you go to water aerobics? And this follow-up is how soon can you take a bath after surgery? So our guidelines are the kind of soaking activities like water aerobics and baths. You have to wait until your incision, or whirlpools, or jacuzzis. You have to wait until the incision's completely healed to this. And that's usually about 3 weeks. Remember, all those things that you get in are not clean. They're clean if you don't have any breaks in your skin, but you certainly don't want to get an infection. That said, though, water aerobics, hot tubs, all those kind of things are good when it comes time to do it. Now, what we do with our patients, as you heard LaDonna mention, we do let patients take showers, though, right away while they're in the hospital. We have a special dressing that actually seals off the incision. And you can go right into the shower the first day after surgery with this dressing on, and then the nurses change it afterwards, and we send you home with a whole bunch of them so you can keep doing that. And it is very nice to be able to take a shower after, you know, all the things that we put you through. So do that right away. Terry, question about bursitis. I have bursitis on both my hip and my knees.
There it is. So there's 78 named bursa on each side of your body. So just you can take home that little trivia. But a bursa is a lubricating sac that occurs in areas of friction of the musculoskeletal system. And if you think about, we have a bursa here in our elbow, there are bursa in our shoulders, there are bursa in our knees. Actually, you know, that kind of that extension of that bursa gives you that Baker's cyst in the back of your knee. And so when we look at the bursa just when they get irritated, they can cause discomfort and pain. They are actually, like in the shoulder, for example, are very intimately related to the tendon, so it's hard to separate out between tendonitis. You'll hear like rotator cuff tendonitis or bursitis. The bursa is right there as well, and so it's a cushion. In the hip, it's interesting that if you look at hip pain from arthritis, it occurs in the groin usually. On the outer side, over the bone there, a hip pointer when the football player falls there, that's where you have the bursa. That's what's called the trochanteric bursa. And that actually responds very well. I like injections there. It responds well to injections. The shoulder and ball responds well to injections. So that's bursitis.
And again, that's completely different. I know, like Terry mentioned, a lot of people think because they're hurting on the side of their hip, they have hip arthritis when it's bursitis, completely, because that's non-operative. So you're lucky if you get that diagnosis when you come into the office. Two questions that are similar. It says, oh, here it is. I'm just starting to have knee problems over the past year and a half, but it's not so much pain as I have a noisy knee. And this is before surgery, no surgery. And then it's sort of what causes the cracking in the kneecap. Anton, you want to do that one?
Again, we talk about today that probably the pain is a major issue and major reason to do something surgically. It all depends on the age of a patient. If you have noisy knee, could be different reasons. It could be a meniscus in your knee, and it's the worst one if it's noisy, but it's also if it's locking, for example. Then something has to be done to it too. But if it's just make noise, I would just leave it alone. I would do nothing.
Definitely pain, right? Now, and again, think of it two different ways. If you have bone on bone in your knees or your hip, that definitely patients complain of noisy knees or a feeling of grating, and they usually feel it more than people hear it. That's one end of the spectrum. There's another end of the spectrum. The kneecap is a free-floating bone, and it rubs in a groove on your distal femur, and it's a little groove. And many times if you get some kneecap irritation, there's a fat pad in there. It gets thickened, and it actually gets in the way of the kneecap rubbing. And you can literally get, without bone on bone now, you can literally get a cracking or popping sensation because the fat is getting pushed out of the way as you bend your knee. So that's the most common reason for people to have noise in their knee without arthritis. And it usually doesn't require surgery either. So again, that's a good thing to have.
It's always in our heads, I guess. If it's something is clicking, there is a famous study that was done on VA patients, and it's impossible to do it at McGee, but they did arthroscopy on arthritic patients, and what they would do for half of a patient will really put the arthroscope in and wash all this debris out of a joint, and another half they would make a little incision on the skin and just pour the water. The patient thinks they are doing something, and the result was amazing. Both of the groups did well. It's basically a famous study was done on VA patients.
They use holy water on the second one. Actually, there was a question about this too. One of the questions was I had knee arthritis, and I had an arthroscopy to to theoretically help the knee, but it was worse after the knee arthroscopy. Why?